All right, now we're going to discuss decreased DLCO, decreased diffusion capacity of the carbon monoxide molecule. COPD has decreased membrane surface area, so you're going to have decreased. Restrictive lung disease, because they're going to have increased membrane thickness, decreased DLCO. Pulmonary embolism, you have decreased blood flow. Blood flow is the key. If the blood flow is increased, you're going to have increased DLCO. If it's decreased, you're going to have decreased DLCO. Pulmonary hypertension, anemia, you have decreased carrying capacity, so you're going to have decreased DLCO. Standing, if they happen to do it with standing versus sitting, or Valsalva, the blood goes back in the heart, you have less flow. What causes DLCO to be elevated means more blood in the lungs. So what examples are alveolar hemorrhage? You're going to have a pool of hemoglobin that carbon monoxide can bind to. So if the patient has alveolar hemorrhage, you're going to have a pool of hemoglobin that CO2 molecule can bind to. Remember, more blood into the lungs causes elevated DLCO. Exercise, more blood in the lungs, elevated DLCO. Chronic heart failure, more blood in the lungs because it's not coming out. Mitral stenosis, another example. ASD, VSD can also be examples of having more blood in the lungs and having your DLCO be elevated. PAD and polycythemia, these are also more blood in the lungs. And then asthma, this is how you differentiate asthma from COPD. COPD, you're going to have decreased DLCO. On asthma, you can have normal or increased. So they're going to be similar on their FEV1 FVC ratio, but in asthma, you're going to have a normal or increased DLCO. In COPD, you're going to have a decreased DLCO. In squatting, if you happen to have the patient squat inside the pulmonary function chamber test. More PFT pearls. So the patient has reduced lung volume in normal DLCO. What is this going to be? Reduced lung volume in normal DLCO. This will be neuromuscular disease. So they're going to have low volumes because they're going to be able to not be able to take that deep breath in to get that negative pressure to be able to get the volumes up, and they'll have normal DLCO because there really isn't anything wrong with the lungs themselves. This is a neuromuscular disorder. This is outside the lungs, not the lungs' fault. Reduced volume and reduced DLCO, pulmonary edema, okay? So reduce volume because they have the water is full of lungs, reduce the DLCO. It's going to slow down the diffusion capacity of carbon monoxide, and you're going to have decreased lung volume because you have water filling the lungs. How about the PFT and pulmonary artery hypertension? You're going to have total lung capacity is going to be normal. Your FEV1, FEVC ratio is going to be normal. Your DLCO is going to be decreased. The musculature of the small arteries are going to have intimal thickening, decrease the volume of blood in the pulmonary capillaries. You're going to have decreased volume of blood in the pulmonary capillaries. How about PFTs for asthma? We talked about this. Obstructive changes with reversible bronchospasm responding to bronchodilators. So this could be another portion of the PFT is seen with the bronchodilator responses by having increased FEV1 by 15%. So meaning that in the PFT lab, you've done your PFTs, then the tech is going to give them a bronchodilator, and they're going to see if they have an FEV1 increasing by 15%. A methacholine challenge test, this can be also done in the pulmonary lab, is where they give them methacholine, they challenge us, and they're going to have a provoked bronchospasm. PFT in interstitial lung disease, you're going to have total lung capacity is decreased. FEV1 versus FVC ratio is going to be normal. Remember, they're all decreased. It can actually be increased too because the FEV1, so the FEV1, FVC ratio are going to be decreased both together, because remember, we looked at that PFT, it's a small lung. It's the same size, same shape, but smaller. And then the DLC is going to be decreased. More discussion on PFT pearls. So remember, why do we do PFTs? Is remember, this is the echo of the lungs. The lungs are dynamic, so they need a dynamic test. So that's why we do PFTs. Can't just cut into lungs. You can't just do a CT of the lungs and say, okay, this is the function. That's why we have to do these testing. Pulmonary function testing is a group of tests that provide data on lung function. Three main components of the PFT is to be the lung volumes, the spirometry, and the flow loops. The lung volumes, spirometry, and flow loops with the diffusion capacity. These are the three components. The FEV1 is the forced volume, the air that person can breathe out in the lungs in 1 second. The FEC is a forced vital capacity. It's the total volume that can be forcibly expired during a maximal inspiratory effect. So breathe in, that's why we have we have a great technique. Breathe in, breathe in, breathe in. Now hold it, now breathe out. That's how they get a great test going. Diffusion capacity measures the ability of the lungs to transfer gas in the blood. Continue discussion on our PFTs. Bronchodilator response is a positive increase of FEV1 greater than equal to 15% or FEV by 200 milliliters in giving a bronchodilator. Lack of bronchodilator response does not preclude bronchodilator therapy, means that you would still give this. So say, for example, the patient didn't have a great response, you still would give bronchodilators. This just gives you information on how reactive these lungs are to bronchodilator therapy. Normal FEV1 and FEC are 80 to 120% of predicted. Remember, they got the age, the gender, and then the height, and we're getting prediction based off that data set that was obtained many years ago. FEV1, FEC increase ratio is going to be restricted. FEV1, FEC ratio less than 70% is going to be obstruction. All right, so let's go over some real quick intrinsic causes of pulmonary lung parenchymal disease. Remember, inside is the lungs problems inside, idiopathic pulmonary fibrosis, COP, which is cryptogenic organizing pneumonia. So cryptogenic organizing pneumonia, what's an example of that? Say a patient comes in, and this is kind of an autoimmune disease, and a patient comes in, looks like they have pneumonia, and you treat them, and they say, you know, I'm not feeling better. Provider, I'm not feeling better. And then you do another follow-up chest x-ray, and you look at the pneumonias in a different area. That's when you think of cryptogenic organizing pneumonia, COP. You may have heard in the past of BOOP. They got rid of BOOP, they changed it to COP, okay? BOOP is gone, COP is in, until they change it back again, right? Extrinsic, outside the lungs. This is not the lungs' fault, it's outside the lungs. Kyphoscoliosis, remember here is we're bent over, hunched over, kyphoscoliosis. How about conditions that we're going to say outside the lungs is going to have a pleural effusion because it's in the pleural cavity, not in the actual lungs, in obesity. Remember, obstructive is when the air has trouble flowing out of the lungs, floating out of the lungs. And why is this? So we'll think of COPD or emphysema is, remember, those neutrophils have broken down in the COPD, so the bags or the alveoli, they're weaker, like an old balloon where the air is, they're kind of a saggy balloon, so you can blow them up, but it doesn't retract as well as a nice fresh balloon where it retracts back in. So obstructive, remember, air has trouble getting out of the lungs. DLCO, remember, this is the diffusion capacity of the lungs for carbon monoxide. Yes, we're not trying to poison them. We're trying to look at giving small doses and see how it transfers over the alveolar surface to the red blood cells. High DLCO can be in pulmonary hemorrhage, polycythemia, asthma, right to left intercardiac shunts, because remember, there's more blood, pulmonary hemorrhage, more blood, faster transmission of the CO molecule, the carbon monoxide molecule. Normal DLCO is with obstructive component, asthma, bronchiectasis. Normal can be with obstructive component of asthma, bronchiectasis, and chronic bronchitis. Normal DLCO with a restrictive pattern could be morbid obesity with pleural effusions, kyphosis, neuromuscular disease. Low DLCO with obstruction is going to be an emphysema. Low DLC with obstruction, that's how we determine between the two, between asthma and COPD. Low DLC with restriction, idiopathic pulmonary fibrosis, sarcoidosis, and asbestosis. Low DLC with restriction is idiopathic pulmonary fibrosis, sarcoidosis, and asbestosis. All right, we're going to go through some slides. Right now, this is some pictures. This is a cross-section. Remember, we're going through the CT scan as cross-section. It's a cutting as this patient goes through the CT scan. This happens to be a patient who had COVID-19. And just look, these lungs, look at this, all this fibrous tissue in here. And look, imagine how hard it is to breathe with this. All right, next one we're going to talk is, this is atelectasis. Now, you look at this, you say, well, that's a fusion right there. No, it's atelectasis. See this difference right here? It's subtle, but you have to learn. Is a shift towards the tissue. See that shift right here? That's atelectasis. That's a shift towards. Now, if this was an effusion, it'd be pushing away, pushing away. So these are subtle differences that you can learn to read on looking at simple chest x-rays. How do you get good at chest x-rays? You look at chest x-rays. You look at the chest x-ray first, then you look at what the radiologist states is the diagnosis. And that's how you get good at reading chest x-rays. Remember, we're having a shift. We're going to erase this so we can see this again one more time. Boom, boom. Okay, now let's take a look at this. Atelectasis, we're having a shift towards the affected tissue, shift towards the affected tissue. Pleural effusion, you can see right here, see this is a pleural effusion. Now, see this is the closophrenic angle right here. Closophrenic angle, or the closodiaphragmic recess. You can also hear that term. If you can't see this, and this is, say this is covered right here, this is an estimated 250 milliliters of fluid right here. Estimate. This is an estimate, okay? All right, here's an example of a pneumothorax. This one is kind of a chronic one. This patient has had a pneumothorax for a period of time, and they kind of sealed off. This is a pneumothorax. See the difference right here? The air right here, this darkness, that's air right there. This is a chronic pneumothorax. Right here, now take a look at this and see if you can see this. This is on a PE protocol. We have a saddle PE. See this right here? This is where the contrast, see here, this is contrast flowing through, and right here is we have a PE right here. This is a saddle PE at the saddle P right there, because the contrast is included or excluded from there. All right, now this is a patient with COPD with sarcoidosis. So first we can see the sarcoid. See these right here? Right here, look at this right here. Right here, this is the sarcoid. Now, in looking at COPD, what things you see in COPD is you see the heart is shift downward. Normally the heart is going to be kind of flat on the diaphragm. In COPD, I want you to think of the lungs being long and the heart gets pulled down. This is a patient who has an x-ray. They have idiopathic pulmonary fibrosis. This is a chronic and progressive lung disease characterized by scarring of the lungs. Now, is the CT more sensitive? Yes, it's definitely more sensitive, but you can see it in this patient on the chest x-ray. Here's another example. This is a patient with idiopathic pulmonary fibrosis. This is on a CT scan. You can see it much better right here. See this right here? It's kind of called janky looking tissue right here, janky looking fibrosis. Just imagine how fibrous these lungs are. Right here, see this right here? This is a bleb, okay? A bleb. This is a subpleural collection of air within the visceral pleural, typically less than 1 centimeter in diameter. This is a really big one. This one is clinically significant because you worry about this patient, this blood rushing, and then they can get a spontaneous tension pneumothorax. What do we have when we have a spontaneous tension pneumothorax? What we want to do is we want to open up air in there. So we put a needle. We would put it on the side where we have the pneumothorax. So we'd feel 2 down right here, 2 down, and we hopefully have a decompression needle. If not, we can use a large needle. And we go in there and we decompress. We let that air out. We release that tension so that the patient doesn't collapse. Because what happens when this blood breaks, it's going to boom. It's going to push over. So this lung tissue, which is oxygenating and ventilating right now, is going to be pushed over and not be able to do this. So what happens? It can die. It can die. So this is something we want to do is feel 2 down, okay, 2 down, and then midline, and we place our decompression needle. 2 down, midline, and place a decompression needle. So a bleb is a subpleural collection of air within the visceral pleural. And this, when they break, the clinical significance, this can have a spontaneous tension pneumothorax.